Audio test, audio test. All right, everybody. Welcome to those online. Welcome to those here in the room this morning. We are going to get started. Our first presenter is Jen. She's going to talk a little bit about herself, and she's got her presentation today. And then we'll keep on rolling with the morning sessions and then right on into the afternoon. So anybody got any questions before we get started? All right, I'll leave it up to you. Should probably talk to you. That's the video right there. And then there's your mute button if you need it, but it's all yours.
Okay. Good morning. My name is Jen Schaeffer. I'm a nurse practitioner with Dr. Lazier here in Aberdeen. And I've been in the allergy and asthma immunology world for about 10 years, but I've also taught up here at PC. So this is kind of like coming home to come up here, which is kind of cool. But I'm also somebody who's actually suffered from and had anaphylaxis from an allergy injection. So having been on the epi side of things and been on the patient side, it's kind of a, I don't know, like coming home more or less, but see if I can get this to work. Okay, it's stuck now. Oh, go that way. So objectives from today, this is actually what Michaela sent me. So we're going to talk about the physiology between allergies and anaphylaxis. We're going to differentiate a mild or localized allergic reaction compared to anaphylaxis. Talk about the medications, and there are some new treatments and guidelines out there in the allergy world that I'm just going to touch on so that you guys are aware of the changes that have been made. And then we'll spend a little bit of time if you want to play. I brought some trainers for EpiPens. So that's kind of our plan for the next 45 minutes, roughly. So first thing, what's the difference between an allergic reaction and anaphylaxis? Allergic reactions are hyperactive, localized responses to an allergen. That's kind of the key. Usually you'll see some redness, swelling, hives, itching, nausea, vomiting, and or even diarrhea. We do see the GI symptoms. Normally, this means that they just need some minimal support. It might be just watching for a while. It's self-limited, and repeat exposures can cause and lead to anaphylaxis, but there's no guarantees. So we always want to make sure the patient is aware. Bee stings in food are the most common. Usually with food, especially, second or third time, you'll see an increased reaction, whether it's tongue swelling, itchiness, that kind of thing. And bee stings, the first one could be a small localized, the next one could lead to full body hives or actual anaphylaxis. Anaphylaxis, remember, biggest thing, I guess, and you all probably know this, it is life-threatening. There's a massive histamine release when anaphylaxis occurs. That can end up with vasodilation, increased capillary permeability. That sends the patient into shock most of the time. Bronchoconstriction and mucus production also happen, makes it a lot harder to breathe. So obviously our airway is the most important thing there, along with the soft tissue swelling of that upper airway can lead to obstruction. Questions between the two, pretty easy. Like I said, a lot of this is probably ultimately review for everybody. But what can cause anaphylaxis? There are a ton of things. Biggest thing being idiopathic. We don't know initially what causes the patient to go into anaphylaxis. Drugs, foods, and other causes can be. Foods most common, peanuts, tree nuts, and seafood. And actually, as of last November at our last allergy conference, sesame seeds has been added to the top list. Most people don't realize that when it comes to even eating burgers that have a sesame seed bun, and then they will have a reaction and have no idea why. So that is the newest food allergen that has been added. Medications, including aspirin and NSAIDs, can cause anaphylaxis. Obviously, we've talked about venoms, latex. Now, in most of the medical world, we've gotten rid of latex, but It does still happen. Actually, we found an old box in our clinic of latex gloves here just a few months ago. So it can still be out there. Like I said, in my case, allergen immunotherapy can lead to anaphylaxis. And we have, I mean, there are a lot of patients that don't follow the rules and stay in the clinics, and then ultimately might end up calling 911 from having a reaction from their allergy shots. And then exercise and animal and human proteins are the other two main things that can cause. What are the symptoms? This chart kind of gives you a brief look down of things. Most common being skin symptoms are the urticaria, angioedema, hitting almost 90%, all the way down to something as simple as a headache. When it comes down to it, like in our case with allergy shots, we tell patients even as little as an itch, a sneeze, a cough that wasn't there prior to, can all be the start of an anaphylactic reaction. It can start what seems like not a big deal and progress pretty quickly. And so the meat of today, ultimately for you guys, how do we treat it? Medications, obviously. We'll look at all the different EpiPen and their options that are out there. Benadryl and Zyrtec is the newest thing that's been added, actually, and we'll talk about why here in a few minutes. Volume support, oxygen, bronchodilators, recumbent position for the patient. And then if the patient obviously can't be stabilized, we continue with CPR and ACLS. The key with anaphylaxis, though, is even if you don't know what the trigger is, the treatment is always going to be the same. So no matter what, if you come up on the patient, you don't know what's going on, we still treat it the same. Most common meds that we use on most of your ambulances, you guys have EpiPens or Auvi-Qs or a mixture of what? Epis, almost everybody's got Epi. Okay, so most common thing people think of when they're having either an allergic reaction or anaphylaxis is Benadryl. That is a first generation antihistamine. It blocks the histamine receptors, but a lot of times Benadryl knocks everybody out and they're sleeping, which can make it hard to really watch respiratory status, especially for patients that are at home even. I mean, yeah, they go to sleep. We hope they wake up and don't have further reactions in the end. But Zyrtec is the newest thing, like I said, that was added. It is a second generation antihistamine, so there's less side effects. It does have a similar onset to Benadryl, and it lasts longer. Benadryl is so short acting that a lot of times that's going to be an issue. So the new guidelines say that Zyrtec is actually a better choice than Benadryl due to how the patient can react to it. So I did add that in today. Epi reverses many of the effects of the histamine because it does, in the end, bronchodilate and vasoconstrict, which ultimately kind of reverses all of what's happening with the anaphylactic reaction. We have to keep reassessing the patient. In our clinic, we always tell patients not to split their EpiPen twin packs because of the short duration and the fact that they may need an additional dose. So we always tell patients keep them together. Plus the fact that obviously they're not tested to make sure they're going to fire correctly. One of my nurses, her sister is a nurse, has a son with a peanut allergy. He had an exposure that they didn't realize was happening at first. When she went to give him his EpiPen, she hit the car seat instead of the child. Another reason why to keep the EpiPens together, because in the event something happens, especially with patients, I mean, even in the medical field, I mean, if it's something going on with my kids, I try to be mom, not medical person, and our adrenaline gets up there and things can happen. So when in doubt, I always don't split the EpiPens because you never want to be in a situation where you don't have that second one if you need it. Normally 30-minute window for a twin pack is what Dr. Lazier tells patients. That gives them 15 minutes of protection. The old guidelines used to be that if you use your EpiPen, we had to tell patients go straight to the ER. New guidelines say if you use your EpiPen and your symptoms resolve, you do not have to go to the ER. And that really came about during COVID. trying to keep everybody out of the ERs. If they use have to do a second dose, then they are still required to go to the ER to ensure that they have coverage. So that's a couple things that have come up that are new. There used to be concern out there that epi would make heart issues worse if the patient had AFib, or that it could cause a heart attack. That is not correct. Even if the patient has any kind of heart symptoms or heart history, it will not make that worse in the event. Not using it is obviously going to be more of a potential issue than using it. So, questions at all on that? I'm a video person, so we're going to try to make this work. Maybe it worked earlier. There we go.
This simple 30-second method reverses memory loss for good. It's so easy, you can do it from the comfort
Love
of your
ads
own.
on YouTube. So the things patients ask me a lot, at least in the clinic side of things, is how do I know if I need to use my EpiPen? Well, in reality, if they're thinking, do I need to use it? They probably already should have used it. And they're like, that's their big question. They're always afraid to use it if something's going to go bad. And the key is, if you think there's something not right, you're safer to use it than you are not to use it. Anybody have questions? There's one other video. I found this kind of neat. It actually shows the difference in how it actually gets like injected into the body on all the different EpiPens that are out there. But questions at all? That's why I like being the 8 o'clock person. So the new reality of life now, and this is post-COVID, is they are still good 1 year past expiration date. So it's always the prescription that I write that I tell a patient, I hope you never really have to use this, but they are good 1 year past expiration. They should not be kept in cars in the middle of summer, dead of winter. They need to be kept at a like room temp in reality. If the window on, if I grab a trainer out, I'll hold this for the video here, but where the lot number is on this trainer is on a real EpiPen, the window. We've all probably seen that. As long as that fluid inside the EpiPen stays the same as it was when they picked it up from the pharmacy, it is still good. So you don't have to replace them every single year as soon as it gets expired. The cost of EpiPens anymore is a lot of times what keeps patients from even wanting to get them but the cost of an ER visit, ambulance ride, any of that is a lot worse in the end. So I tell them, take good care of it. Keep it on you. Don't leave it out in the winter, in the dead of summer in your car. It is good at least 1 year past. So if you can get a couple years out of it, makes it a little bit more cost effective to have on hand. There are insurances that are actually now making us order AviQs, which is nice for the patient because it actually talks them through exactly what to do versus having to remember. Kids as young as, well, we carry one for my oldest daughter who's now 16. She's had it since she was 5. And my girls have known how to use them and what they're for since they were very young. So we always tell patients, anybody that they are with, if it's a parent, the kids should actually know where mom and or dad keeps their EpiPen. How do they use it? Why should they have to use it? Kids, we tell them if you're going to be with your teammates, anybody, your friends should know that you have it in your backpack and what to watch for. Kids very young can understand what they need to do. So, good question. It's hard to tell a patient to keep something past its expiration date, but it really is okay.
There are 3 simple changes I tell all of my arthritis patients to make. Number 1, you have to start drinking more water.
Oh, wrong. Click on the right video here. This should be the one. No. Sorry, I'm not technologically. Oh, it's the same one. It won't work. Shoot. Okay, so I don't have the other video for you guys. Sorry. They're both the same. Clicking. Michaela, do you know why? Okay. Are you good at figuring out? Because it should be, this is the one I want to pull up. But it's linking them together for some reason.
Is this linked on the bottom one?
Oh, that's what.
It's up there.
Okay.
As you can see, I have 4 different epinephrine auto-injectors, and I'm going to fire 2 of each of these devices into this block of ballistic gelatin. So I have a Mylan EpiPen, an Impax Lineage generic epinephrine, it's a generic for Adrenaclick, an Emerad epinephrine device, this is available in Europe, and a Kaleo AviQ. So first, the epinephrine device. Remove the safety cap. One, two, three. Hold it for 3 seconds. As you withdraw, the safety cap comes down over the needle. You can do that again. Again, you hold the EpiPen for 3 seconds now. 1, 2, 3. The Impax Lineage generic device has 2 caps. You hold this device for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It has no needle cover, so for safety, you put it back in the case. One, 2, 3, 4, 5, 6, 7, 8, 9, 10. The AviQ device.
If you are ready to use, pull off red C2 inject. Place black end against outer thigh. Then press firmly and hold in place for 5 seconds.
So this is the nice one for the patients because it tells them what to do.
1. Injection complete.
You will notice with this device that the needle came out, injected the medication, and retracted back into the device. We'll watch that again.
To inject, place black end against outer thigh. Then press firmly. 5, 4, 3, 2, 1.
See, there's no
Injection
exposed needle.
complete. Seek emergency medical attention.
And the MRAD device. One, 2, 3, 4, 5. Again, the cover comes down over the needle, so there's no exposed needle. Notice that the MRAD has a slightly longer needle. 1, 2, 3, 4, 5.
In this video, I'm going to show you how I went from being a burnout doctor,
Okay.
overworked.
So kind of a neat way to see how they actually inject. And like I said, insurances are actually starting to have a lot of patients go to the AviQ. And in the event of emergency, it is nice to have something talking you through what to do, even if you have no medical background at all. Makes that one a lot more preferred. It's about the same price though as an EpiPen is for patients. So I left us about 20 minutes to practice with an EpiPen. So as a reminder, trainers look just like the other ones, except there's no needle. So first thing you do, take the blue cap off. It's outer thigh. Doesn't matter, right through close. 1, 2, 3. And then the cover will automatically cover the needle. Right through anything except just make sure, I always tell a patient, not through seams. You want to make sure that needle actually goes into the skin. Parents are always worried about the safety of going through clothes and what's that going to do to my child for infection rates or anything like that. And it doesn't matter in the situation you actually need to use this. Practice, pass them out, let you each do one. Right.
I have a question.
Yes, Chuck.
How much has EpiPens came down in price?
The last time I paid for them with our insurance was over $700 still. For one twin pack, it cost me $704, I think. On I will tell you, I have terrible insurance. What? There's a 2-pack. Yeah, cost me $704.
You do have a special stash in the office, don't you?
We have vials of Epi, so I mean, because of the allergy shots, but so that's why, I mean, I can rationalize it out. It's $350 a year to protect my daughter. She's worth that, I mean, to me. So, but it is, I mean, $700 just boom for most of us in this world is a huge chunk of money to just pay for an prescription. Prescriptions anymore are getting horrendous. So, but yeah, they're not cheap. So there used to be coupons online. I have not looked lately to see if there's anything out there. But I do recommend to my older patients that actually have to carry EpiPens, when they're looking at the prescription plans, I always tell them to look and see medication list versus what's covered and find the right plan that gives you the best coverage. Because you don't want to be at the point where you can't afford to have a medication to save your life. Other questions?
Once you guys do some training, we We have one group up front there and the cameras, the guys online.
Okay, so
There's some of the EMR students, Vicky, maybe a group leader, some of the EMR students. Yeah.
Vicky, you want to come?
EMR students, you're gonna go with Vicky to, she's gonna kind of walk you through it. You guys probably already. So EMR students will go down there with Vicky or come back up here with Vicky and then practice. 1, 2, 3 in the back. 4, 5. Maybe you can jump over. You're not- Why was this?
They will. Okay. So yeah. Just push the orange tabs together and it will slide back. Yeah. Otherwise.
This is 10 seconds.
It's only 3. These are the old. Oh, I get it. So the new guidelines. The new guidelines are 3 seconds. Oh, your finger. How do you say those? Yes. You don't realize how hard you have to push these through, and that's how we get all the. You good? See, that was pretty good.
And you're gonna be. In the thigh, yeah, you want to, in that muscle. And that's where you have the greatest muscle. Doing it in the thigh, it's easy access. I mean, you have to front, especially like. Well, it's pretty darn, but reality. Yeah, it is. It's a good issue. Yeah, it's hard to know. It's not gonna I know I would also find wearing so then you can see, but you also realize how it's gonna leave on the right it's gonna shine the light right off doesn't matter. Yeah. At least 15 minutes. But when I travel, I take one and if I take else they know. So, yeah. If you're
And the crazy thing with that nutrition side is obviously average 6 to 8 hours later.
It is, and there's.
I started my started where
And now.
everything else. Yes. So in reality, Okay. So for the question of what do you do with an EpiPen if it's expired, but it's never been used? It really should go in a med box. And there are the drop sites around Aberdeen at least where you could put like unused meds. But it really shouldn't be thrown in the garbage. So when in doubt, even take it to a clinic. At least at our clinic, if you're in Aberdeen, you can bring it to us. We'll put it in our med boxes and dispose of them safely that way. But it really should not be thrown in the garbage because it is still technically an active med. And I wouldn't recommend necessarily just poking it into something to waste it. I would just dispose of it in a clinic setting or a med box. So, good question. No. Yeah, because in reality, it probably would still work. The efficiency and the effectiveness of it might be down a little bit, but once you pass that 1 year past the date, but it's still not safe to give out to anybody. So we do programs with schools and we get them free EpiPens to have on hand so that parents don't have to provide for their children in the schools. We actually have a program that we work with. So if you ever hear of a school that really is in need of it, they can always contact our office too, and we can help get them set up with EpiPen Juniors and EpiPens. So, but Chuck, did you have a question? Sesame seeds is the new added, it's been added to the list of the top food allergies. And the top food allergies, almond, beef, chicken, egg, cod, milk, shrimp, soy, walnut, wheat, and sesame seed are the top 11 food allergies. So, and people cannot believe that you can be allergic to beef and chicken and have an anaphylactic reaction, but you can. So, we all think, shrimp, seafood, and we think of the nuts, but there are other common foods that can cause anaphylaxis for a patient. So.
I had a good question that might be good for overall.
Okay.
Because they do make the Epi Juniors.
Right.
30. So what would be their age? When would you use an Epi Junior?
Usually it's 45 kilograms. So if the patient weighs more than 45 kilograms, they can have an EpiPen adult, the 0.3. Anything below that, they should have the junior.
No, she can't see it.
So, yeah, figure 90 pounds.
There's
and
another
above.
question that I'll send you on.
Oh, okay.
But you can't see it on this one.
Oh, okay, sure. Okay.
But what about if they have from the cold, they get uremia from the cold and it affects like the facial or anything like that, should that person carry it?
Depending on what else is going on, that's a hard question to answer based on just cold urticaria, if they need an EpiPen, but possibly they may, depending on what happens. We actually see that with kids that jump into cold swimming pools even, but usually there's other things we try first before we go straight to Epi. But okay, question online. Is the program for school EpiPens available statewide? I believe it is. How many services follow the new pull up and administer IM? I say you're gonna have to
Yeah.
answer that one.
So how many of your services in here do the new Epi draw? You're pulling it up? Are you guys doing it? You talked about it, right? No? Discussion? So that is an option to cut that cost down. That's what happened. I think it was 2 years ago. In the state legislatures, they allowed BLS, passed a law to allow BLS to do that Epi draw. And that's something you have to work with your medical director on. And I know there's probably, just shooting from the hip here, I'd say probably 40% of the services across the state, they're doing that. So we're not there where really where we should be yet, but I know some of you run into those issues with your medical directors that don't want to train you guys how to do that, because that's really what has to be. Your medical directors have to train you. So.
We actually were do that. Actually, you have to have either like medical director, nurse, or paramedic.
Yep. 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 But you have to get it in your protocols, and I think there's some generic protocols out there for that. By the way.
Could you explain that, John?
So Jen's talking about the pens, the cost of them. So that was one thing 2 years ago that our lobbyists with the EMS Association picked out as something that we need to do, where they'll take the vial of it, they'll get the vial of it. Like Jen mentioned that they have vials in their office, and then you'll have the small needle. Help me out here if I'm stumbling.
Yeah, no, you're-
The small needle, and then you'll just inject that into the patient. So when you do that draw, do you inject in the same spot?
We inject in the arm in the
Okay.
office with the draw.
You're just using a syringe.
Correct.
Yep.
Yep.
Oh,
So the vials, are they, do you have to use it all, or do you have to? No, we have multi-dose. Mhm. Yep.
all right, any other questions? You have anything left here?
I don't. I
Okay.
am done. That's it for
Sweet.
me. So,
Awesome. Well, thank you very much. It
absolutely.
was very, very informative. All right, we're gonna take folks online. If you have a evaluation or whatever we're calling them. If you have those, go ahead and take that. We'll take 10 minutes. Let's take till 10 to 9. Take a break, get the coffee filled. I think coffee's here.
Coffee, we got donuts, got them
Yep.
all set up. We stocked the water at the top. We stocked everything, so everything's ready for you. All right.
So we'll come back on at 10 to 9.
Well, thank